Welcome back from the break, everyone. I hope you are well caffeinated. And I would like to say thank you to Carl and Byron for really setting the theoretical stage for the rest of this conference. And certainly also for the next presentation, or presentations, I should say, because we're now very excited to present to you the results of our project, really the fruit of the labor over the past 4 years. So this will be a 3-presentation session, commencing with Christiaan speaking about how the results of the effectiveness study, and then followed by Professor Tracy Finch presenting the ITFIELD's toolkit and the process evaluation, and we will close with Etzelmüller presenting the implementation as usual part of our research. So let me just introduce the speakers to you. So Christiaan, you've already met this morning, and Tracy Finch is a professor of healthcare and implementation science in the Department of Nursing, Midwifery and Health at Northumbria University, Newcastle upon Tyne in the UK. Tracy's research focuses on the social, psychological, and organizational aspects of implementing new interventions in health and well-being. Tracy is known for her work in implementation science, most notably the normalization process theory, as you have heard about now, of which she is co-developer, and for developing tools and assessment instruments to support also non-academic users conducting implementation work in practice settings. Her research applies mixed methods in relation to a broad range of health issues, including mental health, intervention and services for older people, patient safety systems and healthcare experiences and e-health interventions. And Tracy is leading the work on implementation science and knowledge mobilization as part of the Northeast and North Cumbria NIHR Applied Research Collaborative. Anne Etzelmüller is a clinical psychologist and a researcher. She's currently working at the private company called Hello Better and at the Department of Clinical Psychology and Psychotherapy at Friedrich Alexander University of Erlangen, Nuremberg. Anne does research in clinical psychology, in digital mental health and implementation. During the last years, she has been involved in several randomized controlled trials and open studies with a focus on evaluation of internet interventions under routine conditions as well as their implementation. Currently, Anne is involved in projects concerning the evaluation of internet-based interventions under routine conditions and improvement of the implementation of e-health in many places in Europe. So a very warm welcome to this extremely qualified trio presenting now the results from the ImpleMentAll study.
Yes, thanks, Kim. And I'll be doing this, or at least start off with the effectiveness study results. And I must say we have about 3/4 to tell you about what we found and what we learned throughout this project is just a limited amount of that. And we would be happy to discuss that later, and obviously in all the publications that follow, seek debate with you about how to interpret everything that we've been learning here. So now I'll try to share my screen. That's always a challenge there is, I think. Yeah. This is on behalf of the third work package in ImpleMentAll. We have got a couple of those work packages, and this one was really about trial management and trial coordination of the effectiveness study, and played a pivotal role there. And on behalf of that team, I'm very happy to share with you the results. Just a very brief overview, just to give you a bit of the background there. The rationale of this whole ImpleMentAll project has been trying to come to something that you could call evidence-based, or at least evidence-informed practices in terms of implementing evidence-based clinical interventions. So what we actually would do is with a sociological perspective, look at the process of implementation and try to improve that process in which people work and act together to make that implementation. And it's important there to distinguish indeed this sociological kind of perspective, in my view, which I think is the deliberate and planned process of incorporating these innovations in practices. And together with that, that really takes place in a context in which I think to make a successful intervention work, tailoring is key in terms of fitting the needs and in terms of addressing the issues that are in that specific situation. And for that, we define tailoring as this systematic process of identifying the problem, selecting and designing a solution, and then apply that. And that is the key essence of, I think, the intervention that we've been developing and we've been testing in this project. So for the study perspective, we have got two main aims, and I'm very happy that we got that in this study, I think, on equal level. We have an effectiveness study, which examines the effectiveness of the It Fits toolkit in relation to usual implementation. And we have a process evaluation to just understand the mechanisms that are in the toolkit in terms of working with the toolkit. And that's something that Tracy will detail on later on in this presentation. I do want to mention this, really, Jeroen Ruwaert and Kim, you mentioned him already. He was key in developing this project, not only before the start of the project, but also in writing the bit and getting it done. And his, let's say, view on this, and we've talked about that a lot, is let's try to get one number right. We are doing research in uncontrolled settings or less controlled settings, in practical settings, to get a good view on tailoring, to get a good view on the heterogeneity. But still, let's emphasize trying to get at least one number right instead of 100 numbers a little bit right. So less is more. That was the thing that we really started off from. Important here is we have an implementation object, and that is internet-based cognitive behavioral therapy for depression. I'm not a clinician. I have no idea actually what it is about, but I've been told that this is for mood disorders. And the organizations involved in ImpleMentAll all decided prior to ImpleMentAll to implement this, or were already implementing the ICBT services. And the ICBT services were varying. They all had the same basis, the same evidence basis in terms of cognitive behavioral therapy. They all had components of delivery through ICT, so you can think of a website or an app by which patients can communicate with the therapist, get information about the therapy, etc. But the location of the service in the healthcare system, for instance, primary care versus secondary care, differed. The actual platforms differed. The guidance levels differed across all these sites. So we had loads of heterogeneity in that sense also for the implementation object. And yes, heterogeneity has been a challenge in this project, and it is still a challenge in trying to understand what the results are. So yes, this is something to consider. We also had some assumptions here and a hypothesis about the effectiveness study. So implementation is object specific, contextual, takes time, and it's characterizes the existing work in that sense. We have implementation as usual, and we assumed that to be generally unsystematic, intuitively driven, pragmatic, and also often top-down oriented in terms of decision making. And again, these are assumptions, not necessarily the truth, but rather assumptions for our study. And we thought that to improve or to speed up the implementation process, perhaps, we might want to provide a systematic theory and evidence-informed process for people who are tasked with implementing ICBT through developing tailored implementation strategies. So for the effectiveness study, the hypothesis was really, we think that systematic and evidence-informed tailored implementation will lead to better implementation outcomes than implementation as usual does. And that's the main question of this study. So what is then ITFITS? And much more will be discussed about throughout the conference later this afternoon, but also tomorrow. Just very briefly, it's an integrated step-by-step work progress. It's not rocket science. It's about identifying the problem, tailoring solution, taking action, monitoring, iteratively and in adaptive ways. It provides some evidence-informed materials about barriers and strategies, the things that Byron also mentioned there, working principles, etc. One thing that is important there, and I hinted at already earlier on this morning, is that the toolkit will not provide a correct answer what to do. It hopefully provides flexibility to implementers to seek their own answers, which are evidence-informed and informed by stakeholders. Basically, that's the toolkit. So then for the design, the overall design of the study, and within this design, obviously also the process evaluation took place. But we had a step wedge, RCT. So we randomized time trends basically across the sites. And yes, there were things happening across sites. So in Australia, we had bushfires. In other countries, we had indeed, like Kim already said, earthquakes. But all these occurrences, so to say, were randomized in that sense. And what is key here is we have repeated measures. So wave 1 until wave 10, we repeatedly measured the primary outcome, which is normalization, NOMAD, based on NPT, basically. And that's on individual level. The staff that were involved in service delivery and needed to implement ICBT, those were the objects of our study for the primary outcome. And on secondary, we also looked at uptake on organizational level. And you could see that as does uptake increase when using the toolkit. And in the graph here, you see the gray areas, that's implementation as usual. So we have a before-after comparison, basically. And the green areas is the period in which sites were using the toolkit for their implementation. Then just a few words on modeling, because this is much more complex in that sense, but also not so much. Important here is that staff, which was our unit of study, so to say, are nested in organizations, and we assumed that staff within an organization are likely to be responding similar in that sense. So for that reason, we took a generalized linear mixed effects model approach to this. And again, the idea here is to look at if we could see a change actually a jump in normalization, which we can relate to the intervention being introduced in a site, the crossover moment in that sense. So then to the results. Let's see what happens when you do this in practice. And we've had 39 different people working with the toolkit in 12 organizations. So basically we had 12 teams using the toolkit to develop strategies. And we had 456 unique service deliverers as our respondents across this time of 30 months, basically, of study, which I think really this is a extraordinary result of the trial sites being able to address these people, because these were, for instance, therapists who are very busy, but also GPs involved in ICBT, which are notorious for not responding to questionnaires, for instance. You could also see here, and that's interesting in my view, that almost 75% or 74% had no prior experience with ICBT, meaning that these people needed to go through a change process, a process of normalizing using ICBT in their practices for delivering services to their patients. And that's important in that sense. If you look at using ITFITS and fidelity, a question of fidelity, all teams received an introductory training, and all teams received a monthly support group calls during this exposure period, this 6 months, which were really of a technical nature. So we didn't have this expert-driven perspective to it. Rather, the toolkit was a sort of standalone self-help tool in that sense. But we gave it a training. And fidelity and exposure, for the exposure, it's clear to see that all sites that used the toolkit finished also modules 1 to 3 as per protocol within the exposure period. So we could safely say that this sites were exposed appropriately to the toolkit per protocol, but it's very much also subject of process evaluation, what that really entailed, the exposure in that sense, and the fidelity to the things in the toolkit. Interestingly, also implementation teams were generally satisfied and also found the toolkit usable. And again, this is obviously a lower number. It's 12 teams using the toolkit, but it's indicative at least that the toolkit is usable and it workable in that sense. Then looking at Nomad. So these are, again, staff who are involved in ICBT services, and at the start of ImpleMentAll, most of those were new to delivery of ICBT. And interestingly here is that the response rate, and I need to click this thing away, response rate is 78%, which is very high in my view. Again, compliments to the trial sites. We had a power calculation being performed on 1,800 data points, and we well achieved that with over 1,000 more. So I think quantitatively we are well powered and well positioned for at least assessing Nomad. Okay. So this is the graph. This is observational. So what happened actually here? This is normalization per organization. And the red line is the moment of introduction in the toolkit introduction in the sites. And the right-hand side of the graph is the time that teams use the toolkit, and the left-hand side is the time that sites used implementation as usual, or did their thing as they would normally do. And what you actually see is that, well, every site basically, or every mean in organizations are around neutral or a little bit above neutral. And obviously also there is some spread. So some organizations are more enthusiastic than others. But it's clear also that the lines are quite flat over time. And there is not a major jump in change or in normalization score per organization before or after the introduction. So if you then do some modeling and try to estimate the effect, try to come up with a formula that can represent that line, basically that we've been talking about, then you can see that there is a small significant positive effect by the toolkit related to the toolkit. It is very small, so it's 0.09. It is, on the other hand, it is statistically significant, but it is again very small, especially taking into account that we have a 5-point scale like it on which the staff members were to respond to the items. And nevertheless, I think it is there. What is interesting as well is that we found a temporal effect, meaning that if you don't use the toolkit, we see a very slight decrease over time of normalization. And that's interesting, I think, in itself, but it's obviously a bycatch in this result. So again, small, significant, but positive effect. If you then look at, again, the graphs, and this is interestingly, I think, just also for people who are into the data, so to say, the Adrians of this world, you see the gray lines, those are the individual responses, and some sites, they are very wide and let's say variant of each other. Other sites, they are a little bit more closer to each other. But again, it's quite a flat line. And this also holds for the different constructs within the Nomad questionnaire. So if you talk about coherence, making sense out of something, it's also quite flat and follows the mean in that sense. Then for the secondary uptake, secondary outcome, this is work in progress. It's more difficult. So what I show here is really observational, no modeling in there yet. And one of the things there, the reasons is that we've seen quite some scale differences between the sites. But interestingly, if you just look at the graphs, you do see changes over time. So this is what happens if you calculate the delta, so to say. But also, interestingly, is that you don't really see necessarily that the increase, or if you have an increase in referrals to the service, it's not necessarily that the same increase pertains into completers, so people who received adequate exposure to the ICBT service. So that's one thing. On the overall given, we had around 7,000 people referred to the services, 20% finished their treatment in a way, and 73% stopped their service. And obviously we need to talk about why that is, what happens there, and how that relates to literature on the services. But again, this is work in progress. Coming back to the main question, nearing the end of this very quick overview of the main results, does ITFITS do better than implementation as usual? Yes, I think it's safe to say that it does if we measure normalization, but with very small effect sizes. And likely, or one of the things that might happen, obviously, is that we did have a more or less longitudinal approach to measuring the outcomes, but that the effect of the implementation activities that were undertaken by the implementation sites saw their effect even after this project. And very much also context dependency there. So again, do we think bigger, faster, more? Yes, it does change and tweaks and modifies implementation slowly, but not yet in a very radical way. So it's modest, but it's there, and that's a good thing to take away, I think. So for the discussion, take into account that we, from the effectiveness study perspective, looked at an aggregated effect across all the sites, with all those differences and with all the restraints of time and etc. And we piloted black box, the black box of ITFITS, in which has numerous components which we thought, when designing the toolkit, were important to facilitate tailoring. And importantly here as well, when writing the bid and getting it funded, we were obviously very ambitious, and even started from scratch with the whole intervention, starting from a new idea on tailoring, obviously in building on other research there, but really from scratch. And we did a full-scale trial as well in this project. So perhaps we should really view this as a large pilot study. It's small effect again, but numerous questions we can ask. Is it expected? Can we expect more? In that respect. The implementation object is ICBT in itself very difficult to implement. And we also have a natural laboratory variability that we need to represent the complexity of context. But it also poses limitations of measuring change and standardizing and doing, let's say, experimental research in that. And I think it will start, I think we need to have discussions about the theories that support this, both on the concept that we have of tailoring, but also perhaps on the processes of normalization. Again, really, I think the main takeaway here is, yes, the results are small, but they indicate that it is worthwhile to perhaps take another step in this endeavor. And of course, heterogeneity, not without any spice, but that's just for the fun of it. It was also just good fun to do this. So thank you very much. This was my talk about the effectiveness study. And obviously there are, again, like I mentioned, loads of questions. But first, I think it's very good to have also an in-depth view of how people use the toolkit and better understand how they work with it. So over to you, Tracy.
Hi, thank you very much, Christian. I'm just looking to see if I can share my screen. Okay. excuse me while I just Okay, well, thank you very much for inviting me to talk about the process evaluation results of the ImpleMentAll project. And thank you very much to Christiaan for setting up this presentation. Okay, so I'm talking about the process evaluation of the ItFits toolkit. And what we really aim to do in this part of the project was to understand how the toolkit works in practice in the context of the study, and to understand the mechanisms that shape that work that was being done. So our research questions were, how do the IMA implementation teams engage with the toolkit? How is the toolkit itself reconfigured and adapted within and across the different settings that took part in the project? And what factors shape this? So this was a longitudinal process evaluation that commenced as soon as the sites, the first 2 sites crossed over into the active phase of the trial and therefore received the toolkit. And it continued until the last 2 sites had completed at least 6 months of working with the toolkit. So we undertook data collection in the 12 trial sites, as well as an additional site that took part in the project, but not in the data collection. So we had 13 sites. And in total, we conducted 55 interviews, which involved 30 different participants across the sites. So the interviewees for this study were implementation leads, core team members, and stakeholders who were relevant to the projects in some way. And the number of interviews each per site varied from 2 to 7. And at times, multiple participants could be in a single interview. So some of those involved more than one person. The interviews were also supplemented by observations from the support calls that Christiaan mentioned, where some of the sites in the active phase came together to seek some guidance, mainly on technical issues, but it was an opportunity to hear a bit more about what was happening. And so those sites included those calls included multiple sites at the same time. Our approach to data analysis followed established procedures for qualitative research. And it started really as soon as we got the first transcripts back from the first interview. So right from the start of the process evaluation, we were analyzing data. It was very collaborative. It involved a team that extended it was a very iterative process. really with flexibility in mind. So the intention here was to provide implementers with more options for approaching their work. And in normalization process theory, again, we might talk about optimizing the workability of the toolkit. And one of the 6 principles that we set out as part of the toolkit package was to really encourage implementers to think differently and to think outside the box and to try strategies they hadn't tried before. And one of our interviewees here sort of spoke to that, explaining that the strategies, the list of strategies that had come from the ERIC compilation had been really helpful and comprehensive. It included some things they were familiar with, but also new things that they wouldn't have necessarily thought of without the additional guidance. And important to say, there's a reference here about adding extra strategies, and we built the toolkit flexibly so that they weren't just restricted to what was built into the toolkit. They could add strategies of their own into the platform and work on those. So, Professor May, in his opening plenary, talked about this ongoing process of negotiation, and this really came through in the data that we looked at in the process evaluation. And one of our intentional mechanisms, if you like, within the ITFITS toolkit was to work with stakeholders. And our model, which you'll get to hear more about during the conference and see the more detailed presentation of that, involves iterative cycles of stakeholder engagement in each of the 4 modules that the implementation teams progressed through. So working with stakeholders was really key. But of course, and it also reflected one of our principles, which was to be open to stakeholders and to be prepared to adapt plans accordingly. We did see that this involved teams bringing together different ideas, interests, positions, and sometimes needing to agree a compromise in order to move their projects forward. And that was mostly described as really valuable, but it could take some more time. Internal and external issues and events impacted projects across all sites. And some of these are the usual things that happens in organizations. They include staff turnover, including in the implementation teams themselves, or other unexpected barriers to getting on with projects, perhaps getting things authorized and signed off, alongside quite significant events such as earthquakes, bushfires, and of course, towards the end of the project, we had the coronavirus pandemic. Also important to point out, and Professor May did touch on this a little bit also at the start, it is, when we're doing this implementation work, it is often in the context of a project or a trial. And here we did see some ways in which the context of the trial itself affected some of the projects that were undertaken and the way that the implementation teams went about their work. These factors were both facilitating in some ways and constraining in others. Certainly it brought some resource, there was a real sense of motivation, and our interviewed participants reported having found the wider support structure of the ImpleMentAll project team really helpful for undertaking this work. There were also indications, though, that this situation may have influenced some of the projects and the decisions that they made in terms of the scopes of the implementation projects that they designed and they implemented. But it's important to bear in mind that that will affect the work in some ways. So in terms of ITFITS Sustain Beyond the projects, implementers differentiated between the online platform itself, the digital platform and its contents, and on the other hand, the learning that might come from the experience of using it and applying it in practice. So some spoke of taking forward the ideas from the toolkit rather than necessarily using the very structured step-by-step process in the actual toolkit itself. But others found that it was quite helpful, and even if they had their own ideas about what steps to take and what projects to do, it was a good reference that they could go to just to keep a check on and to guide their work. So there were some ways in which it seemed that the toolkit could go forward in some forms. In conclusion then, our results overall showed that the ITFITS toolkit was workable for the implementation teams, that once they became familiar with the structure and the process, they could work with it flexibly to plan and execute tailored implementation strategies. The ITFITS toolkit did change the way that implementation teams worked. And for example, it gave them a systematic structure, a process, but also enabled them to work a bit more creatively. It's important to acknowledge, though, that the process evaluation focused on how implementation teams worked with and utilized the toolkit. So it was beyond the scope and power of the study and our part of the study to really assess the effectiveness of specific strategies the teams developed. So we know that they changed the way that they work. They know that this work was focused around tailored implementation, but understanding the impact of those specific strategies needs a little bit more exploration and testing. As Christiaan mentioned before, timelines may have also been a contributing factor to some of the progress. And in Module 4, for example, implementers are asked to review the success of their strategies. And it may be that there may not have been time, certainly for some sites, perhaps the ones that came on later on in the project. And that is all. So thank you very much for listening. Oh, and now I would hand over to Anne Etzelmüller, who will talk about the implementation as usual study.
Thank you, Tracy. Okay, yeah, I will present the implementation as usual evaluation of the ImpleMentAll project on behalf of a very huge team of evaluators in this group across work packages. And this work focused on the implementation as usual evaluation, which means that we only looked at these data that were collected before implementation organizations started to use the toolkit. So what we wanted to know more about is relevant determinants of ICBT implementation and the activities that sites execute to foster implementation. And with this work, we are of course building onto the existing literature of determinants of implementation and strategies or activities to foster implementation, but here we really focused on ICBT implementation because we think this is a specific circumstance of implementation work within using complex systems within complex systems. So we thought this is worth investigating some more. We used the interviews conducted within the ImpleMentAll process evaluation. So all the data that Tracy was describing before, but we only used the retrospective information on the time before the sites started to use the toolkit. So in the first interview, we asked them, what have you done so far? And what have you experienced so far? And this is the information that we analyzed for this evaluation. The work was a big team effort, and the analysis plan was already described in the previous presentation on the qualitative analysis. We evaluated 64 interviews and mainly took information from the first interviews that were conducted when sites were introduced to the toolkit and were answering our questions retrospectively. 70% of the information was provided by the implementation leads, and our final coding system, which was an open coding system focusing on determinants and activities, consisted of 93 first, second, and third level codes. And I'm going to present you now our first results, trying to aggregate these information into something that will hopefully inform ICBT implementation in the future. So for the determinants, which can be facilitating factors, but are also barriers to implementation, I was trying to find a good way to depict what we found, and I came up with the iceberg, because when we are looking at ICBT implementation, we see some services and projects where the translation from research into practice actually can be successful, and this might be to a certain degree successful, but we have existing ICBT services in routine care and some amount of access to it for users. But what we know from the literature and what we hear basically every day when we're talking about digital mental health implementation is that the implementation of such services is still lagging behind expectations and also the promise that these interventions might have. So what we did was really focusing on what is underlying to these two observations, which might be a little more hidden in our everyday practice. And what we found were 4 specific components here that might be relevant when we're talking about the implementation of ICBT services. And those were stakeholder characteristics, components on contextual level, continuous use of the service, and service-related determinants. With regards to the stakeholder characteristics, we found that attitudes of stakeholders are very relevant to ICBT implementation, as well as their views on mental health, including stigma, e-mental health, and the specific ICBT service that was implemented in the organization, as well as the outcome expectation regarding that service. Also, the knowledge that they had about e-mental health implementation, mental health in general, or the ICBT service, as well as the awareness of those services were relevant factors. Regarding the continuous use of the service, factors such as the adherence to the service, referral and referral pathways and referral procedures, as well as eligibility criteria, which are still a very prominent thing in routine implementation, have been found as relevant to the implementation, as well as the services positioning within the mental health care system. On a more organizational level, we found that roles and role clarity of service deliverers, implementers, and other stakeholders are very important, as well as the workload that this often additional service might introduce, or the workload that the implementation itself might introduce. A very common theme was also introduced as the personnel changes in those teams and what they might mean for the implementation processes. And another important factor was resources, of course. On the contextual level, we found that the integration and the way the service was integrated in the healthcare system was relevant, as well as stakeholder engagement, identifying relevant stakeholders, and the relationships those stakeholders have with each other. Also, legal and ethical aspects were very important, and the perceived or actual level of control of all involved stakeholders within the system. On the service related side, we found that the complexity of the ICBT service might influence the implementation, as well as the participant fit. So who is the service being developed for? And are those people being reached as the target group that was expected? Connectivity and access. So does this new service can be used with existing service and other technical and IT aspects? With regards to the activities, we found some obvious and less obvious activities, such as the direct measures to increase reach, which include activities such as widening the geographical reach of the intervention to have a higher potential to involve more clients or users, changing referral pathways or adding new referral pathways, as well as dissemination and communication activities. With regards to the integration of the service, it is really about the contextual fit and also changing the service to make it fit within the healthcare context, especially when it comes fresh out of a research project, possibly. And also creating a service that has some kind of familiarity in the system. So what we heard is that implementers try to make the service look like something that stakeholders in the healthcare system are familiar with. Adaptation of the services, which can be adaptation to the context, language adaptations. An important part was the education and training of relevant stakeholders, and here again also, as was mentioned before, the continuous retraining and train-the-trainer procedures. Improving stakeholder engagement was something that was very prominent in the data. Ways to identify and engage and inform stakeholders, which can be stakeholder meetings, communication and dissemination activities. Then from the business development perspective, which was a little bit less prominent in the data, but very distinct to potential implementation plans. Then the factor of learning practices, which means ways to inform and learn about similar services or inform others about the service in different ways. Monitoring of change processes, as well as research activities, and providing technical assistance. And those can be easy activities such as bug fixing or helping the user to find the right password. To conclude my presentation, I want to highlight the continued discussion among the evaluation team. We're going to look at different components in the data, such as code co-occurrences, also between determinants and activities, and the potential comparison of activities in the implementation as usual condition to the active toolkit use. We're very much looking forward to the finalization of the results and the scientific publication, as well as the dissemination and continued use of our results, for example, in the next version of the ITFITS toolkit. Thank you very much.
Thank you, Christiaan, Tracy, and Anne for this very nice presentation of the results so far. I think definitely we'll dive into these results much more over the coming, I guess, years, really. This is a massive data set, so we expect many interesting publications coming out over the coming years. So all of you interested in that, keep an eye out for these publications.